left off with, again, with forearm positioning, really fundamentally forearm positioning, wrist positioning, elbow positioning. As far as the positioning goes, really, they're very similar. As far as lateral goes anyway, you know, with the wrist, of course, we shoot PA, but everything we want in the same plane for different reasons. With the forearm and the elbow, that's to prevent the anatomy from being, you know, kind of rotated. So on a test, you're going to have the most complicated thing that's going to be on the test is detecting rotation or tilt of the forearm or the shoulder and where the anatomy is going to appear, right? So what you have in the elbow is, you know, you've got two different condyles, one on top of another. And but what we want to see is we want to see the two condyles stacked on top of each other so they appear to be a round circle, right? And we're not going to see that on the lateral forearm because of the divergence of the central ray. We're going to have projection and they're not going to be superimposed, but on the elbow they should be. So here, you know, we don't see a perfect round circle. We see a little bit of a double halo because it's forearm because of the divergence of the central ray. So on the test, you're going to have to be able to identify what's going in what direction for a lateral of the elbow. So what you're going to want to look for are those two condyles, right? So you've got the two condyles. They should be perfectly superimposed on the lateral elbow, and if they are, then you have that really nice, perfect round circle. But if you have any kind of deviation in your positioning, then you're going to have a difference in that. So how you tell the way the patient was mispositioned is by looking at the condyles, certainly, but also what articulates with the condyles. So going back to positioning or anatomy, really what you've got is two condyles and you've got two articulations, right? So you've got the radial head articulates with the capitulum. If you can remember just that, and I walked through it in the first semester talking about, you know, you open the car hood and what's way up at the front that cools your engine? It's a radiator, right? So if you need to take the little round thing off of the top of that, round thing being the key word there, you unscrew that, it rotates and you take it off. We call that a radiator cap, right? This is a radiator cap. So the word association, radius articulates with the capitulum, radiator cap. So if you can remember that, the other two go together, right? You got to know the names of them, but if you can remember radiator cap, you can remember radius articulates with the capitulum. So that's what you're going to be looking for essentially is which of those condyles looks like it's articulating with the radial head, right? So the second thing that you have to remember is that those condyles are on the humerus, right? So you're going to be looking at this image or maybe a description of the image. And a description may be, it might say the capitulum is projected distal to the trochlea, okay? So we're talking about though the anatomy of the humerus, right? So just real quick, brief recap of positioning. You want everything in the same plane for the lateral with the thumb pointing up, right? So this, all in the same plane. And the difficulty comes in when you can't get the patient down low enough, or sometimes you get the patient too low, the elbow's elevated, or the shoulder's elevated. And then also you have a problem with, you know, the tilt of the forearm. So what you're going to be looking at is that articulation between the radius and the capitulum. Those condyles are on the humerus. So the distal end of the humerus is down here, right? This is posterior portion. So if we have the radius, the radial head and the capitulum projected that way, then that's going to be, what is your orientation there? It's going to be distal, shoulders elevated, and it's going to be distal, right? So then if we have the capitulum well, I just gave that away, that way, then what do you have? You've got the hand elevated, the elbow depressed, and the capitulum is going to be posterior. Okay, so it might take you, doing a little bit of positioning of yourself. I think there's 4 questions just on that rotation of the elbow in all 4 possible, orientations. Lateral elbow is very important to get, and I will show you why here in a minute. But I think you've got 4 questions on that, so it's really important that you understand that. So if the hand is down, the elbow is elevated, then the capitulum is going to be that way, which is going to be anterior, very good. And if it's, this way, then that's going to be proximal, very good, okay? So just position yourself in it. And the reason that it's so important, I've kind of touched on it on a video before, the reason it's so important, do you like a little Popeye? Yeah, when I first started doing this, everybody knew who Popeye was. I don't think as many people know anymore, for Popeye's lost to history. So with the lateral elbow, it's the thing that's going to show us the most stuff. So you've got 3 fat pads. They're fat pads of interest. I'll show you those here in a minute. I don't know what that is, but it needs to go away. It still needs to go away. So what you've got is 3 fat pads. I don't know that they show up there all that well, but you've got the supinator fat pad just anterior to the radius, and for whatever reason we can't see it. And then you've got the anterior fat pad that if it swells out and away from the distal portion of the humerus, that gives us what we refer to as a cell sign. Okay. Cell sign is an indicator that maybe there's something a little bit more significant going on with distal portion of the humerus, maybe a fracture we can't see. This posterior fat pad, which you do see here, is normally inside the olecranon fossa, and you don't see it at all. So if you see it, you got a fracture. Probably more than 9 times out of 10 there's a fracture there. It's significant enough to displace that. So if you see that, then it's an indication of fracture. The thing is, if you've got any kind of tilt in the, in the arm, it's going to tuck that away from it's going to tuck it back up under the humerus. So again, consider it's back here. You got the hand elevated. Then that fat pad is going to roll, right? It's going to roll, and you're going to project the humerus on top of it. So you got to get everything in the same plane. Otherwise, you're going to miss your telltale indicators that you got a fracture. This guy has got a fracture of the radial head, and I just don't know why we're not seeing the fat pad there. So maybe a little bit better demonstration. We've got the cell sign out here. Really, it looks more like a beak to me, and then we've got the posterior fat pad again visualized there. So we've got some other things too. The head of the radial head can be broken off and show in a little bit of a different place. So it's kind of difficult sometimes to see on lateral. So you got to kind of take a look, but what you don't see up here is radial head. So this is radius, and the radial head is snapped, and it's way up here. So I don't know exactly how that happened. Where it should be is right here, and where it is way up here. So these are just images I pulled off the internet. Most of the time, your elbow fractures, if they're not like that last one that we saw where the radial head is in an obviously bad place, then they will probably just sling it, possibly cast it. I thought I saved the ORIF, but they can put let's say in this case, if we're looking back at this one, they can put a pin through that and a little plate down, kind of like what you would see on a hip nail, to surgically repair it if the fracture's bad enough. Most of the time they'll just sling it, cast it, something like that. Okay? So really important to be able to visualize good lateral of the elbow. If you can't get the patient in a good AP position, AP projection, the hand supinated, then you can do that two view that we talked about in the freshman year, where you do a partial flexion of the distal portion of the humerus, proximal portion of the forearm. And in both cases, you're going to have some elongation, or I'm sorry, some foreshortening of the anatomy that's not parallel to the image receptor. And it's not ideal, but you can still get kind of a frontal view of it. So remember, on your APs, you're going to have a little bit of superimposition on the between the radial head and the proximal end of the ulna. Radial tuberosity is going to be superimposed, so you don't have a complete desuperimposition here. So what we'll do for possible fractures of the radial head, or the neck and the radial tuberosity, where we can't see it on the AP and possibly can't see it on the lateral, or obliques. We only had one clinical site in recent years that did a full series on elbows, and that was AP, a lateral, and both internal, external oblique. But what you're going to see on those obliques is something different on each one. Get the skeleton down here. So you don't get that desuperimposition on the AP, so we got to do something else. And what we're going to do is we're going to take and if we externally rotate, and this is just not going to cooperate with me without putting some body English on it, but if we externally rotate, all right, see what happens whenever I rotate inward as opposed to rotate outward. We externally rotate, and it's not going to cooperate at all. Then what we will do is we'll project the radial head and the radial tuberosity, this bump that's now out anteriorly, we'll rotate that out and away from the ulna, okay? So your external rotation is going to desuperimpose those two things. And what it's going to take to get a person into external rotation is you're going to have to put some body English on them, all right? So you're going to have them really lean out that way. Otherwise, if you just do that, chances are you're not going to get enough rotation in the elbow. You have to have the patient lean in that direction. Just externally rotating the arm is just not going to do it. Internal rotation is going to show you, it's going to greatly superimpose everything, but the one thing that it'll show you is the anterior most portion of the cornoid process. So this thing will be sticking out anteriorly. Full disclosure, I've never seen a fracture of that in my career. I'm not saying it doesn't happen. I'm just saying that possibly of the four views, that would carry the least amount of information. The lateral is the most important. I would say possibly followed by the external rotation, even though the external rotation is probably not going to be your, in a lot of hospital routines or clinic routines, external rotation might not be there. It may just be a two view. So that's what you're going to be looking for. Again, your rotations, what we have here is a external rotation. That's not really internal rotation. It's somewhere in between. It looks like what they've got there is an AP of the elbow with a lateral of the wrist. But external rotation, you get desuperimposition of all that stuff. All right? So internal rotation, there's your cornoid process there. External rotation will get desuperimposition. Lateral, it's a little fuzzy, but otherwise it's really pretty good. Fat pads, we talked about, so we're not going to go back through that. Okay, so positioning errors, just make sure, this is probably most common if you have the patient get down on a knee, right? If you set a patient in a chair, you've got a little bit more control, but if you put a patient down on their knee, in a lot of cases with the table all the way up, the patient's going to be in a position like that. You're going to have that desuperimposition of condyles. All right. So any questions on lateral elbows?